Hello, everyone. Welcome to the Ancillary Withdrawal and Medication-Assisted Treatment webinar. We are going to give people another minute or two to get on, and then we will get started. Sit tight, 1 to 2 minutes at most. Thank you, everyone. Welcome, everyone. My name is Carla Licio, and I am here at the National Center on Addiction and Substance Abuse, also known as CASA, and the Managed Care Technical Assistance Center. And joining me today is
Zoraida Diaz from New York State Oasis, Practice Innovation Care Management Unit, rather known as PICM, and I'm happy to be here.
So welcome, everyone. Zoraida and I today are going to walk through some slides on ancillary withdrawal and medication-assisted treatment. A couple of points for everyone to know about this webinar. We are not providing live Q&A on this webinar. However, we do welcome your questions and your input. At the end of the webinar, at the last slide, Zoraida Diaz has kindly offered her direct email. We encourage you all to make note of your questions throughout the webinar and send those questions to Zoraida, and Zoraida and I will work together, as well as enlisting the forces of Oasis, to respond to all of your questions. So please take note of your questions and send them to Zoraida. Also, for any of your staff that may benefit from this webinar but were unable to attend, this webinar will be available on the MCTAC website, which can now be found at ctacny.org, and that address is also available on the last slide of this webinar. It usually takes a day or so for a webinar to get loaded up on the website, so there may be some delay, but you will be able to find both the slides and a recording of the whole conversation here today on that website. Also, while you're on that website, I'm going to make a pitch now and at the end of this webinar to check out the 4 videos that are loaded on that website regarding ancillary withdrawal. 2 of those videos are created by Steve Kipnis and Rob Piculel, and the other 2 are an interview with Dr. Charlie Morgan discussing implementation of ancillary withdrawal. So again, I encourage you to find those videos and to check those out and share those with your staff as well. Zoraida, you ready to get started?
I'm ready.
All right then. So our goals for today are both to inform and educate all of you about ancillary withdrawal and medication-assisted treatment, to encourage providers to adopt the service, We're really looking to increase the number of providers that are both designated for the service and are offering the service. And finally, we have the goal of the OASIS system providing evidence-based care in all of its settings by making ancillary withdrawal and medication-assisted treatment readily available and easily accessible throughout the state. Before we get started further along here, I want to take a minute just to put ancillary withdrawal and medication-assisted treatment in the context of substance use disorder as a chronic disease, not an acute disease. In such a model, relapse should be anticipated, planned for, and addressed. Ancillary withdrawal and medication-assisted treatment are the evidence-based practices as long as they are surrounded by the psychosocial counseling and treatment needed to both plan for and address relapse. Zoraida, would you like to start with ancillary withdrawal defined?
So on this slide, you see the definition for ancillary withdrawal services. Some things that I want to highlight is, one, that it is physician and nurse-led. This is a medically supported service, but I need to highlight that it really does take the treatment team to address the needs of the patient. One of my goals, actually, in this position as Coordinator of Crisis and Ambulatory Withdrawal Services for OASIS, is to increase the number of programs we have providing ancillary withdrawal services and increase the number of programs that are designated. So anything that I can do for the provider community to reach that goal, please feel free to reach out to me to facilitate that process.
Zoraida, at the bottom of this page, we talk about improving the patient's ability to engage in treatment and recovery. And I want to take a minute because I think that you and I, throughout this webinar, are going to say that ancillary withdrawal improves the patient's ability to engage in treatment and recovery a lot of times. And the reason we've included this again and again is because the engagement rates and retention rates in treatment need to improve. And engagement rates and retention rates are things that, in a value-based payment world, those are points, metrics that are going to be looked at and measured. And so ancillary withdrawal and medication-assisted treatment are tools that you can put in your toolbox to start to work on those metrics. So I wanted to highlight that right at the beginning, especially since you're going to hear it again and again throughout the webinar. So let's go through some key concepts which basically are related to withdrawal as a biological process. And I want to take a minute here to note that when we're talking about ancillary withdrawal, we are not just talking, and MAT, we also are referring to other substances, not just opioids and alcohol, which are typically thought of. MAT can also be used for nicotine, and ancillary withdrawal can really address a variety of symptoms related to an array of substances that are used. So I just want to highlight that point. Steve Kipnis does a terrific job talking about that in more detail on his 2 videos. So I think a lot of these concepts are things that all of you know, but we thought that it was valuable to just include. Most substances with abuse potential have a withdrawal syndrome. Withdrawal symptoms are the physiological reaction of the body to the absence of the substance. In general, the withdrawal syndrome has the opposite symptoms of the substance taken as the body returns to equilibrium. And these facts really set the stage for treatment that includes medication. it makes the argument that this is a biological process to which medication can directly address. So treatment includes medication with a like substance to slowly taper the medication to reduce the severity of the reaction and slowly regain a substance-free state, or if using a long-term medication-assisted treatment to achieve a craving-free state.
So I think here it's important to say that we are trying to address people's physical symptoms. We are trying to address their needs, maybe their emotional needs as well. Within our detox system, we address their physical symptoms, but once they come out of detox, which is really short in duration at times, we need to be able to address some of their continued systems within our other services, and that's why we are saying that ancillary withdrawal services is important, as well as the use of medication-assisted treatment. It is a chronic and pervasive disease. It is a disease where relapse occurs. And previously, I guess we used to state to our patients that, yes, when you stop using, you will not feel your best, but give it time. Take it easy, give it time, you'll feel better later. And now we're saying, we can provide medications to assist in the process of recovery. You have short-term options and you have long-term options. So we'll continue this conversation in future slides, but I thought it was important to say that now.
Yeah, I agree.
So on this slide, we present withdrawal management services, kind of the spectrum of the services. Withdrawal symptoms have a range from severe to moderate to mild to minimal withdrawal. Within our treatment system, we want to be able to treat all of these withdrawal symptoms. So within our services, excuse me. Withdrawal symptoms that are severe and acute can be treated within our medically managed and within our medically supervised programs, which have 24/7 nurse and doctor coverage. Those services also help people who have comorbid issues. They have physical health symptoms and other maybe mental health issues that need to be addressed and stabilized. So our 816 system is not going anywhere. Our medically managed and medically supervised programs are there now. We'll continue to provide the service, and we will have the service available because acute detox is a level of service that is important and necessary for some individuals. How we're trying to enhance our service is to now address moderate and mild withdrawal throughout our spectrum and now encourage our inpatient, our residential programs, as well as our outpatient services to handle and address mild to moderate withdrawal symptoms. Anything that I'm forgetting?
Did you want to talk about locator here?
Yes. So the locator is there to also assist in the process of making sure that the person is placed in the appropriate level of service, and that is done during the admission process. So you have your doctors, you have your locator, you have your staff all making the appropriate treatment referral.
Shall we move on, Zoraida?
Yes. So here's a look at our service, at our continuum, at our comprehensive treatment setting. So again, on the left side, we have our medically managed, medically supervised, our crisis service. We have our medically supervised outpatient and our medically monitored. what's interesting about the crisis service is that these are our 816 programs, 816.6, 0.7, 0.8, 0.9. They are standalone service just providing this service. All staff is there to make sure that the people are stabilized in whatever way and process that they need. Now, when we look at our inpatient rehab, when we look at our residential, and when we look at our outpatient service, this is where we're expecting more of our mild to moderate withdrawal symptoms to be addressed. And of note, I have to say that our medically monitored programs, 816.9, those are being converted to stabilization programs within our residential section. But again, if you look at the comprehensive treatment setting, here we're seeing the ability to treat everything from acute all the way to mild to moderate symptoms.
So just to emphasize a point that I think we've been making throughout this, ancillary withdrawal is not detox. This is a stabilization process that is set within the context of treatment. It is not designed to be a standalone service. The point of ancillary withdrawal is to improve engagement and retention in treatment and to make patients comfortable enough so that they can access treatment from the beginning, as soon as they enter treatment. I also want to stress that anyone presenting with or developing symptoms of severe withdrawal must be referred to a more intensive level of care. So at no point in time is the expectation that an outpatient clinic would manage a patient that is experiencing or trending towards severe withdrawal. As always, it goes without saying that the goal is to have the patient in the right level of care at the right time in the right place. And again, as Zoraida talked about just a slide or two ago, the locator is there to help you with that process as well. But of course, your clinical assessment is needed.
So this slide talks about protracted withdrawal, and that statement talks about people experiencing symptoms of withdrawal after they've come out of detox, maybe after they've been engaged in treatment for a while, maybe after they've been in the process of recovery for months, 6 months, maybe even a year. And that protracted withdrawal is saying that people can experience cravings, people can experience emotional feelings that may be able to be addressed through medication-assisted treatment. Again, if we look at the disease of addiction as a chronic disease model, then long-term engagement or long-term resources, right? Mm-hmm. Resources for long-term recovery should be made available. Always think about the process as person-centered. You know, our system is one where we need to address people's unique recovery experience and also provide them with as many resources as possible. And when we are trying to have people apply for designation and trying to have people provide medication-assisted treatment, we are trying to make our programs as resourceful as possible. Yeah. And give our clients as many choices as possible to address their own unique recovery experiences. It's not one size fits all, right? But it's about being able to address comprehensively the patient's need. Not everyone will need ancillary withdrawal service or medication-assisted treatment. Maybe they don't even want it. Oh, no, that's not for me, and that's okay. But if we try to educate our patients that there are these resources for them if and when they need, then I think we're improving our services.
That's an excellent point, Zoraida. I want to emphasize also this is an opportunity to highlight one of your goals, which is to make sure that this service is available in as many places as possible throughout the state, in as many different levels of care, as many different doors as possible, so that whatever door the patient walks in, if this is the service they need, that it's something that they could get. I also think this is a great opportunity to highlight that, as we said earlier, relapse is a component of substance use disorders.
Right.
And ancillary withdrawal is a way to address that. Protracted withdrawal is, untreated protracted withdrawal leaves people open and vulnerable to relapse. And our goals are to help people to succeed in recovery.
Right.
And this is a key tool to be used.
And I think it helps engage people too. Sometimes when our consumers relapse, you know, we may think maybe they need to go to detox or maybe they need to go here or there. But if we can address that relapse within the program and say, hey, we also offer this service, maybe this is something that can help address the symptoms that you're feeling, you know, and address them as symptoms, you know, it provides more of a person-centered and engagement approach.
Shall we move on to the next slide?
Yes.
So let's talk more specifically about withdrawal symptoms. So protracted withdrawal are signs and symptoms which manifest over time after acute withdrawal. Typical symptoms, and this list that you see on the screen is not all-inclusive. So these are some typical symptoms: anxiety, insomnia, restlessness, muscle tension, sleep difficulties, etc. To take a side note here, imagine trying to engage in treatment experiencing these symptoms. It's very difficult to sit and benefit, or even just to sit in treatment, let alone benefit from treatment, if this is how you feel. So these are some typical symptoms, but again, individuals will present in their own individual way as well. So addressing associated symptoms with MAT and education and counseling. As we said in the beginning, MAT and ancillary withdrawal need to have education and counseling wrapped around them in order for them to be most effective. They can make someone more comfortable in their recovery process, improving engagement and retention, all of which, just to remind everyone, is something that an MCO, a managed care organization, is looking for in a provider, someone who is able to engage and retain their patients.
I can also state, when I think about ancillary withdrawal services, I also think about the ability to kind of have that warm handoff from our 816 services to our 822 services. So everyone who comes out of detox, you know, yes, they've been stabilized. Yes, they've addressed their, you know, their physical symptoms. But within our 822 now, we can continue to address some of their withdrawal symptoms that they may be experiencing, or within our stabilization program, we may be able to address it. So that continuum of treatment services is really important, and our providers being able to accept our people from the detox programs, have that linkage, have that warm handoff is something that we're really looking at as part of, you know, some of our future measures, initiation and engagement into treatment, as well as use of medication-assisted treatment as one of the outcomes in the near future. So,
Zoraida, you want to talk to the benefits?
I think you know, this is kind of repetitive of what we've been saying all along, that it's not just medication-assisted treatment alone, but it's medication-assisted treatment with good, effective treatment services where you have the individual counseling sessions, the group session, and whatever other support someone needs to be addressed within their process. It's hand in hand, and it's not just Zoraida and Carla saying it, but we see that Samsha also says it, and you know, we're pushing this model as what needs to happen to effectively engage our patients. It's not one without the other, but it's both. You know, the behavioral therapy is as significant as the medication also.
So again, engaging patients in treatment directly at an earlier stage in their recovery reduces opportunities for clients to get lost to care. As Zoraida was saying, strong linkages and warm handoffs are critical for the success of a patient in treatment, and addressing the symptoms of withdrawal can enhance engagement for all patients and reduce negative attitudes and behaviors that interfere with treatment in those patients who are experiencing protracted withdrawal. So what this speaks to is there may be some patients that are difficult to manage in treatment, and it may be that they're difficult to manage in treatment because they're actually experiencing protracted withdrawal, and that's gone unaddressed. And so the symptoms that they're experiencing lead to some of the behaviors that you see in program that make them difficult to manage. By addressing those symptoms, you then may actually get an active, engaged patient. We talked briefly at the beginning of the webinar about the levels of care, and ancillary withdrawal is an opportunity to reduce unnecessary use of inpatient level of care. And I want to stress here that the word unnecessary is important to understand this in the overall structure of the system. At no point in time is anyone looking to take someone who meets medical necessity for inpatient care and put them in an outpatient setting. Again, the goal is to have the right level of care at the right time. And so we do also know that there are patients who use inpatient care despite the fact that they don't meet criteria for that level of care. And ancillary withdrawal is an opportunity to strengthen the outpatient system, the ambulatory system, and the residential system so that those patients don't have to go to inpatient. They can get what they need on the outpatient system. And this aligns with the goals of a value-based payment system in which reducing unnecessary inpatient level of care is a key component. So if you become a provider who can demonstrate that you can do that, then you become, you have leverage within the system. Ancillary withdrawal also improves the patient experience of treatment, and that is a goal of the triple aim.
So I think we've been using the word medication or the term medication-assisted treatment. Here we're going to take a moment to kind of just further process what medication-assisted treatment is and further define it. When I think about the two terms, ancillary withdrawal service and medication-assisted treatment, ancillary withdrawal service can address some of the short-term management needs of some of the short-term management of these symptoms, and our medication-assisted treatment is kind of our long-term. Now, a patient may come in saying that they want to take this medication for only a short time. They're set, right? That's what they want to do. But maybe along the way, they begin to feel that they're more comfortable.
Yeah.
and they may want to stay on the medication for a bit longer. Again, this is where that person-centered process comes in. You give the patient choices. You educate them. You provide them with the medication. You provide them with the ability to make a choice about their personal desires, I guess, as to the medication. Is it something that's short-term? Is it something that's long-term? For ancillary withdrawal services, what we ask for in the process of obtaining the designation is for the doctor to write protocols as to how they would address the withdrawal symptoms that someone is feeling, and what medications they would use, and how they would utilize these medications in the process of their treatment. So again, we see ancillary as more of short-term and MAT as more of a long-term, but in many ways they are part of each other, I guess I would say.
They're part of a bigger system in which medication is used to support recovery. If I could go back a minute and just highlight something, I think this is an important place for us to talk a little bit more about person-centered practice here. So, as we said earlier, education, counseling, and support need to be wrapped around any medication-assisted intervention. And part of that process is to give the patient the information that they need from the very beginning of treatment for them to be educated about the treatment that they're engaging in. And so that as they get further on down the road in their recovery, they can make educated decisions in collaboration with their treatment team about whether or not they follow through with a medication-assisted ongoing treatment or not. They may change their mind over time. The treatment team may have different input as they continue to assess the patient over time. It's not something that gets decided upon intake. It's something that is an ongoing process that incorporates education, patient input, treatment team input, and very importantly, physician input in this whole process. And I want to highlight here, too, that I know sometimes patient-centered care gets interpreted as the treatment provider needs to do what the patient wants. And I want to stress here that, as the slide says, this is a shared decision between the treatment team and the patient. At no point in time should the treatment team throw away their expertise in treatment or their opinion about what needs to happen with that patient. It's something that needs to be shared with the patient and discussed with the patient in a collaborative way. Patient-centered care includes the patient in the process, but the patient doesn't get to trump the process. Maybe that's a bad choice of words this week, or maybe not. No political statement on the webinar. But the treatment team and the patient need to work together with bringing all of their strengths and all of their knowledge into making these decisions over time. Because although what the patient brings is they are an expert on who they are and what their particular life is like when they go home. And so that particular expertise needs to be brought into the conversation as well, but it doesn't overrule the treatment team.
And the treatment team, and I'll just say this because I'll feel bad if I don't say it, but also the medical team is part of that treatment team.
Correct.
And that needs to be highlighted. It's the counselors, it's the medical team, it's a shared decision as to making the best process, and I person-centered process for the patient. You're empowering the patient with the ability to say, this is what I need, this is what I want. and you're educating the patient also with, you know, these are the options for you. Moving on.
So, Zoraida, we decided we needed to throw in a definition of MAT, medication-assisted treatment, and we've included here MSR, which is medication-supported recovery. Just a real quick aside, medication-supported recovery is medication-assisted treatment. It's different language that if you go on the OASIS website, you'll see under medication-assisted treatment that over time, OASIS is looking to move the language from medication-assisted treatment to medication-supported recovery. So we wanted to just throw that in here.
And it's highlighting that everybody's process of recovery is unique, and you know, it's stating that there are different processes, there are different roads, but the world of recovery incorporates everyone.
So again, as we move along in this process of transformation, you'll see medication-assisted treatment, and at other times you'll see medication-supported recovery as we're in this transition, but know that both are the same thing.
One more statement?
Yeah, please. All the statements you want, Zoraida.
The myths and stigma. We cannot forget about the stigma associated with the use of medications. We need to move that bar ahead. You know, we need to continue the fight and say that everyone's recovery process is valuable, is unique, and again, remove the stigma. You know, if someone needs medication to address their disease, then that's what they need, and we need to be able to value, we need to be able to advocate, I guess, and we need to be able to look at our system and move it forward and make sure that we are as an inclusive recovery community as possible.
And to further that, because I think it's so important, you'll see on this slide that we've again quoted SAMHSA as citing, and there's a whole body of research that shows that when treating substance use disorders, a combination of medication and behavioral therapies is most successful. And I think, Zoraida, that we've included this a number of times in the webinar for exactly that reason, that we're trying to drive home the point that this is a science-supported, evidence-based treatment, and that for it, in an effort to fight the stigma that medication-assisted treatment has long held, both within the OASIS system, both within the substance use disorder community and without. And so we want to emphasize that there's real science behind this, behind the value of this practice.
And again, you know, our outpatient services includes our OTPs, and it includes our non-OTP programs. Ancillary withdrawal services can be provided there. It includes our residentials with our stabilization. It also includes our inpatient rehab. So we're not just saying it's perfect for one modality. We want to be able to offer it across our services.
Before we go to the next slide, I just want to point out that we're moving now in the webinar from an emphasis on ancillary withdrawal, which ancillary withdrawal, again, if you watch those videos, you'll see ancillary withdrawal can be used for withdrawal symptoms for a variety of substances, including marijuana. Medication-assisted treatment, you'll see in our next slide, look, there it is, can address at this point in time ongoing maintenance of recovery from nicotine, alcohol, and opioids. So I just wanted to make that distinction that in the webinar now we're moving to a little bit of a focus on medication-assisted treatment. And so Zoraida is going to talk some about MAT for nicotine, alcohol, and opioids?
Well, I think that you see the information here, but again, this is a medically driven, this is doctor-driven. So you see some medications that can be used, but it's about making the patient feel as comfortable as possible in their process of recovery. So the doctor can use other medications that they believe will help the patient to feel better. So this is some, there are more, and when you write your protocols as part of the designation process, you can write to what you believe are the medications that will help someone that is experiencing withdrawal symptoms. So these are some, there are more, and it's up to your doctor to write what they would like to use to treat withdrawal symptoms.
We included nicotine on this slide as a reminder. Nicotine may not be something that is always aggressively addressed within treatment, and yet there are medication-assisted treatments available for nicotine, and you may have patients that are seeking to quit smoking, and this is an opportunity to use MAT to assist in that process.
And now we move on to billing guidance.
This is the most exciting part of the webinar, right, Zoraida?
So,
and yet
the information is you can go to our APG manual online, and I've quoted what pages address ancillary withdrawal services specifically, and then the pages that address our medication-assisted treatment. You should be able to find everything that you need when it comes to billing for this service. On the next slide, we talk about where you can find the information to apply for the designation. Now, applying for a designation is not like a regular certification process. It's not as cumbersome, I guess I would say. It doesn't involve an actual application. It's probably 8 or 9 requirements where you have your protocol, you have how you're going to use toxicology testing as part of the treatment process. You have a part where you talk about access to nursing or doctor staff 24/7. That doesn't mean that you will apply, that you will have a doctor or nurse available around the clock in order to provide the service. What we mean by that is if someone is in your program and they're not feeling well, that they have the ability to call a nurse.
A nurse,
which is a nurse doctor together more.
A nurse.
You have the ability to reach out to a nurse and be able to talk about what symptoms you're feeling or anything along those lines. So it could be having, pooling your resources as far as your program, and maybe you have nurses in some other part or entity, but it just means that the patient should have someone that they can call. So toxicology, and again, you can go to the website to get further information.
Zoraida, when you talked about 24/7 access, that made me think that this is a good opportunity before we go any further on the designation process to talk a little bit about the opportunities that ancillary withdrawal and medication-assisted treatment provide for integration with primary care as a way to develop and access resources that your particular program may not have. So there are certainly programs within the state that have collaborated with perhaps an FQHC,
Federally Qualified
Health Center, in order to provide the MAT service, while the Oasis Clinic provides the counseling service. And those two providers then come together for a holistic treatment of the patient. I raise that only because I'm aware that the resources for staffing can be challenging, and that, as you may have heard in other webinars or other trainings, partnering and integration are going to be real hallmarks of the system in the future, and the future is now. And this, again, is a place where primary care and the SUD provider can come together, each providing one aspect of a whole treatment. So I just wanted to throw that in since we did touch briefly on resources.
Integration is key, absolutely, and there are many different initiatives going on throughout the state, especially through district, where we're addressing integration needs, and this may be something that can help you in providing ancillary withdrawal services. We know that staffing at times can be difficult, but at the same time, we look to you to tell us how you want to design your programs. We have programs that can do inductions for all days of the week, and then we have other programs who do inductions, certain days. It's up to the provider to design their service as they see fit, as the need arises, and you tell us exactly how you would like to deliver this service. Oasis is not telling you you have to do X, Y, and Z and provide it all these days. That's based on you, the provider, telling us what you feel is most effective for your service.
And that being said, know that the managed care organizations will be looking for access. And so it may be worth your while to think about how you can provide this service in the most accessible way, so that if you can, if someone is looking for this service and it's Tuesday, but you only provide it on Thursday and Friday, that may in the future reduce the referrals to your service if there's another service in your region who can offer it every day. So just something to think about.
But that brings up collaboration.
It does.
Right?
Look at that.
and there's enough for everyone, and I think the more that we collaborate as providers, the more comprehensively we can address the needs of our consumers. So if provider A provides this service, these days, and, provider B provides it these days, maybe
and we're partners.
We're partners, or we know of each other's services.
We're part of a network.
Part of a network. This is where we have to think outside the box and, continue to look at the needs and look at how we can address what those needs are, and also the warm handoff is really key. Working with our 816 programs, and being there for those clients that are coming out of that program, and providing ancillary withdrawal services or providing medication-assisted treatment, I think is kind of hand in hand, right? It's another way to further collaborate and further enhance where our patients can go and how they can flow through our system more appropriately.
So I think that we're emphasizing that there are resource needs in order to deliver these services in the best way possible, to provide the most access and to deliver the most comprehensive care, but that you don't have to do it alone, that networking and partnering are ways to make this happen. And so we encourage you to find ways to do that.
Absolutely.
Did you want to say anything else about the designation process, Zoraida?
So let me just quickly go through what are the components of the application. I talked about the medical protocol that's needed. There is the need to have a policy on your vital sign monitoring for your patients, what medications you may use post-withdrawal for them. You need to discuss what accommodations you'll provide within your environment to address this service. And by that I mean within the environment of your agency, are you going to do anything differently for the patients that are going through ancillary withdrawal service? We discussed toxicology testing. You need to discuss how that toxicology testing will be used within your service, as well as linkages. What linkages will you have for within the community to continue the process of collaboration? Pre and post engagement is important. A QA plan, and like I said, a need for 24-hour access. So again, that information can be found right on our website, which is on the slide.
Also, as I said in the beginning, we hope that you visit the ctacny.org website, which some of you may know as the MCTAC website. You go under trainings, you're going to find the ancillary withdrawal videos that Casa MCTAC created. Those are the videos that include Steve Picciolel and Steve Kipnis and Rob Picciolel and Dr. Charlie Morgan. In addition, I hope that throughout this webinar you've been making note of any questions that you have. You'll see Zoraida's contact information here. Please send those questions along and we'll work together to answer all of your questions. Zoraida, anything else before we wrap up?
I think that's it. And again, I encourage you to reach out to me, and I will try to assist in whatever way possible. And yes, I'm stationed in New York, but I do travel upstate also. So if there are any stakeholder groups that you feel a presentation on ancillary withdrawal service, Matt, could be beneficial, I welcome those opportunities to continue to try and create more capacity within our system for these services.
We want to thank you for your time today, and we hope that this was helpful. So again, please send your questions, and we look forward to working with you in the future.
Thank you.
Thank you, everybody.